Good afternoon and welcome everyone to this webinar focusing on health inequalities in diabetes. This is the last webinar in the series, and this series has provided a great opportunity to bring together our clients, our communities and our colleagues. Just to say quickly, thank you everyone for taking the time to connect with us here at Owen Mitchell today. My name is Shannon O'Hara, and I am a paralegal in the medical negligence team in Owen Mitchell's London office. I am really excited to be hosting this webinar here today. As someone with type 1 diabetes myself, this is a cause that's really close to my heart, and I really hope that you find it educational and useful. There is a lot of stigma surrounding diabetes, and a lot of people just don't know the difference between types 1 and 2 and the long list of complications that come with each of those. I'm sure everyone is going to learn something today, myself included. Just quickly, some housekeeping. So thank you to everyone who has already submitted questions. You are able to submit additional questions throughout the session. You should have a Q&A function on your screen, and we will get around to answering them at the end. When you're submitting questions, if you could include your name and email address so that if we don't get to you, then we can respond to you directly after the event. We are recording this virtual event, and recording links will be sent out afterwards so you can watch them later. And towards the end of the session, we will be posting a feedback link. So we'd be grateful if you could just take 2 minutes of your time just to let us know how you think that this event went. It's now time to introduce the real star of the show today, our speaker, Dr. Mark Vanderpump. Dr. Vanderpump is a consultant endocrinologist. He resigned from his NHS post at the Royal Free Hospital in April 2016 after 30 years of service, and he now works full-time in private practice, specialising in diabetes and endocrinology in central London. He was the president of the British Thyroid Association from 2014 to 2017, and he was the chair of the London Consultants Association between 2019 and 2022. So I think we can all agree he is therefore a great person to be giving this talk today. Now to hand over to Dr. Vanderpump.
Good afternoon, everyone. And so I've been given the challenge of describing or discussing health inequalities associated with diabetes and some of those associated health outcomes. So the focus of the discussion is really going to be on type 2 diabetes and obesity. But I will just mention type 1 diabetes because it does have some relevance in terms of this particular topic. In terms of what I wanted to cover in terms of next slide is to just make it quite clear how you diagnose and classify diabetes, in particular the distinction between type 1 and type 2, the clear role of obesity, and therefore those the health outcomes and health equalities of obesity and how wide it's at risk of developing type 2 diabetes. Talk about the complications that are important. I've got a few case studies of some medical legal issues in diabetes, which we can discuss, and then try and bring it all together by looking at what sort of health inequalities implications are. So the other thing I've just put on that slide, and I think it's going to be circulated, is that this is quite a nice sort of paper written by a North of England NHS group looking at various local studies that had helped different groups within their diabetes community access diabetes care. So I thought it was quite a nice way of just going through what the inequalities would be and how one might overcome them in terms of ethnic groups, language barriers, and also social barriers such as patients being managed at home, etc. So that's just a nice resource. So next slide, please. So in terms of the problem, the issue is that diabetes is at least 5% of the population now and increasing with age. The vast majority, over 90%, are type 2. We'll come back to discussing that. So in total, we're looking at a pretty large number of people with this estimated 5 million by the next year or two. What's also clear is that if you go looking for it, and indeed these days it's relatively rare for a patient to become symptomatic and get a diagnosis. Most people are found often by chance on a blood test because there's a long natural history in type 2 diabetes before it does declare. So if you start screening a population, you might find another 1% of the population at least probably also have type 2 diabetes but don't yet know about it. Classically, by the time you got type 2 diabetes, you were said to have had it for 4 to 7 years before you actually declared. There's also evidence that type 1 diabetes is increasing in prevalence as well, and there we can discuss how that might happen, but it's now thought to be an increase in autoimmune disorders in general, which is what type 1 diabetes is, as compared to type 2, which is not autoimmune. It's got big implications in terms of NHS resources, and we'll talk about the complications, as the problem is what it creates in terms of complications and how that affects morbidity. Plus, there is estimates of reductions of life expectancy, primarily due to an increased risk of cardiovascular disease, which therefore means that the management, particularly in later years, is dominated by cardiovascular risk disease management. So the next slide, please. So in terms of how we're defining it, this is a very biochemical diagnosis, i.e. you need a sugar above a certain level, which was defined by the WHO. And interestingly, what they did was they went to a population with a high prevalence of diabetes on a specific island. And there was a specific complication of diabetes called retinopathy, where you have bleeding at the back of the eyes. And what they did was define those who got that complication with their blood sugar. So these numbers weren't chosen at random. They were chosen on the basis of that you are more likely to get complications. So you can have a fasting sugar less than 7 millimoles per litre, or a random one performed at any time more than 11. And there's also this concept of impaired fasting glucose or impaired glucose tolerance, which is sort of the phase before you're diagnosed with diabetes, where you're at risk and therefore another opportunity to intervene. And so what you're defining is type 1, type 2, and I'll just briefly mention type 3C, which is a rare version where people have a primary pancreatic disease through surgery or pancreatitis. So again, a further variant of type of diabetes, which is not linked to the other two, but obviously is pretty rare. The other thing that's become clear over time is that the random sugars are quite difficult to interpret in terms of timing. And so I'll mention again the important what's called the HbA1c, which is a bit like your economy's interest rate. It gives you an idea of where your sugars have been over 3 months. And so increasingly now that's used in the diagnosis, biochemical diagnosis of diabetes. So next slide, please. So this, again, for reference really, is just giving you the different types that we recognize. We've got the pancreatic disease at the end, that type 3C. You've got type 1 on the left, type 2, second column. There's some very rare genetic forms of diabetes. And there's also a further subclassification of a rare form of almost type 1 diabetes, which occurs in older adults. So there is a way now of looking at your specific presentation, age, with other different factors to try and put you in a certain column. And certainly in terms of medical legal work, one can often see a patient classified as a type 2 is actually a type 1 and vice versa. So there is the patient, from the patient perspective, being given an accurate diagnosis is important. And so this is just a reference slide of how we can try and put you in a various column and give you a definite diagnosis of not only you've got diabetes, but what your specific form is. So the next slide, please. So the key thing in terms of the management, and this will be true for all your medical legal reports, is how well is the patient is doing. And so we have a biochemical test called the HbA1c, which literally looks at your average blood sugar over the preceding 3 months. There is a bias towards the month prior to the sampling. So about 50% of the numbers for month 1, about 33% for month 2, and 15% for month 3. So within that setting, this is where we are now deeming people to have good or bad control. And so when you're reading records, these are the sort of numbers that patients will be trying to achieve. So in terms of good diabetes control, this number, there's, just to make things even more confusing, there's a double unit used. There's historically, it was a percentage, it's now moved to millimoles per mole. But you can clearly see, and there's good data we'll discuss on how patients' pathway with their diabetes correlates to how well their control is, particularly in the early years. So the next slide, please. So when we're talking about complications, we're broadly splitting them into two. First thing, I think the key thing here is there's no such thing as mild diabetes, particularly in the type 2 person, in the sense that their sugar component of the problem may be relatively small. But by the time they've got the diabetes, even at that so-called mild end, they are at risk of the complications, particularly the macrovascular complications, which is heart attack, strokes and clotting and blockage of arteries in the legs, which can predispose to diabetic foot disease, and also microvascular, which is the small blood vessels in the eyes, the kidney and the feet. And the feet, small blood vessel problem and the nerve supply problem contribute to the vascular disease and increase the risk of diabetic foot disease. So there's quite a wide spread. So the problem isn't so much diabetes per se, it's the impact on morbidity, which we'll discuss later, and how that translates into your long-term health. So next slide, please. So just a couple of mentions on type 1 diabetes. So this is an autoimmune disease. There is a genetic risk, but actually not as much as we think in terms of type 2 diabetes, where the risk is almost 50% if you've got a mother or father with type 2 diabetes. In type 1 diabetes, there's a clear genetic risk, but for example, if you've got one child with type 1 diabetes, you've got a 5% chance of your next child having type 1 diabetes. So although the risk is definitely there, it's not as great as with type 2. Well, what you need to do is meet an environmental insult that sets up an autoimmune response, i.e. your body attacks itself. That damages the pancreas cells that make insulin, and then you have a rapid progression to type 1 diabetes at a young age, and then when you're older, it can be a much more gradual process. So what you're basically doing is emptying your reservoir of insulin-producing cells within the pancreas to the point that you've got no insulin, and that's why you're always insulin requiring. So if you're looking at the pattern, here's just the age of diagnosis. You can see this big peak of diagnosis at 10 or 12, as we were hearing earlier. And then you still get the odd 1 or 2 people, sorry, next slide. Then I'll get odd people still getting type 1 diabetes even at a relatively older age. So it can be a bit confusing. A 50 to 60-year-old can still present with type 1 diabetes. In terms of management, historically, people have used insulin that's been injected. So there are 2 sorts of insulin. One you inject that lasts the whole time, and then you have another insulin that you inject every time you eat. And this is sort of mimicking the normal insulin response as much as possible. People now use pump therapies more commonly, often combined with glucose sensors, where they're measuring the glucose in the arm. And there's this concept of the artificial pancreas, where the sensor can talk to the pump and make adjustments almost happening without the patient being involved. So clearly a high intensive, now high technology disease with lots of subtleties. So the health inequality aspect is how one would, sorry, the next slide. The health inequality aspect would be how you address that access to both the technology and to encourage people to attend the clinic. So just to look at this slide again, you've got the grey bar looking at that insulin going in the whole time, and that happens to all of us. Then we make a certain amount of insulin every time we eat. And what the type 1 person has to do is estimate how much they're about to eat and inject appropriately according to their pre-meal blood sugar and how much carbohydrate specifically they're hoping to eat. So next slide. So when we're talking about this HbA1c issue, what we're saying is that if you're following up, and this was a famous trial in type 1 diabetes called the DCCT trial, which is the main outcome study trial of patients with type 1 diabetes, some of whom were left with their normal care, some of whom had more aggressive tight glycemic control. And what it showed for the first time 20 or 30 years ago was that the better your control, the less complications you developed. And so this is a very nice U-shaped curve where you can see from 6, 7, 8 to 12% onwards, the rise in risk of these specific microvascular complications of the eyes, the nerves and the kidney. But also note that if you go too far the other way, i.e. your control is too good, that there's also a risk, and that's mostly of hypoglycemia, seizure, and even death can occur with severe prolonged hypoglycemia. So in every individual patient, there's a balance to be drawn to where is their sweet spot in terms of good control, minimizing complications, but not pushing them too far over to the left-hand side. So this is one of the principles of treating type 1 diabetes. And it does become a very intensive process, lots of involvement of multidisciplinary teams, psychology, nurses, dietitians, etc., to manage this process. So the next slide. So turning to type 2 diabetes, and just to give you a sense of this concept of you having the problem long before you know it. And so if you're starting to look at by the time you've got type 2 diabetes, which is in the middle bar here, when your sugar finally starts going up, for many years, 5, 10, 20 years before then, you're starting to see subtle abnormal biochemistry, mostly in terms of your insulin response. So ironically, in this situation, as compared to type 1 diabetes, where you have no insulin, in this situation, you're often making 3 or 4 times as much insulin as you need. It's just not working. So that's the concept of what's called insulin resistance. And that can happen for many years prior to getting the diagnosis or getting the sugars to go up. So when you get the diagnosis of type 2 diabetes, you're combining that insulin resistance problem with finally your pancreas getting exhausted and not able to drive as much insulin. So that's why at the diagnosis, ironically, type 2 patients often have 3 or 4 times as much insulin as so-called normal people without diabetes. The importance of this is that what I was emphasizing in terms of what we call the macrovascular disease outcomes is that risk starts years before you get the final diagnosis. So your lifetime risk of cardiovascular disease is associated with you getting the problem rather than necessarily treating it afterwards, which is an important point. It's not until your sugars start going up that you have the risk of microvascular complications, which is the small vessel, nerves, kidneys, and eyes. Next slide, please. So if we're looking at what drives type 2 diabetes, it's clearly weight. And as you can see from this graph in terms of your risk, once your BMI goes up more than 35, your relative risk of getting type 2 diabetes is more than 90. So a massive association with weight, which has really driven much of the recent advances in type 2 diabetes care. Next slide, please. So I think we always sort of think, is weight health? Is there a health inequality in weight? And actually, surprisingly, not as much as we might expect. So in a sense, the most overweight people tend to be women of relatively low income and men of relatively high income, actually. But overall, the statistics are that most of us, or about a quarter of the population, would be described as being obese, with those slight outliers being young women and being older men as being just on average. So it's quite an interesting association that is not necessarily our income does drive our prevalence of obesity. Next slide, please. What's clear is that obviously our genes have not changed over the last 40 or 50 years. And I often say to people, well, if you can imagine what your genetic component of your height is, you might say it's 80%. It's approximate what your height is, maybe 85. So in a sense, if you emotionally deprive someone, poorly malnourish them, have a chronic illness when you're younger, you might only achieve 85% of your genetic height. Obesity and your weight is driven by at least 70% in some people. So what I'm saying is that you've only got 30% that's controllable in terms of your final adult weight. And so with that genetic susceptibility, it doesn't take much within a calorific environment. And this is just some data from the States looking at available calories, use of sweeteners, and other sort of ways of looking at how the population is exposed to this what's called obesogenic environment, how you can slowly increase, even by 100 calories a week, you can slowly increase your weight. But you don't lose the weight if you take off 100 calories a week. So the general drift is all getting higher and higher. And the more your fat cells swell and gain weight, the more they enjoy it and they want to stay there, and they put more resistance up when you try and lose it. So if you're somebody who's gaining weight very easily, it usually means there's a very strong genetic component. And the genetic component that enables you to gain weight is precisely the defense mechanism that's there to stop you losing it. So you end up in that vicious cycle where your weight climbs and climbs and climbs, despite you making increasing efforts which don't seem to be proving successful. So next slide, please. So as a consequence, as people are aware, the obesity rate is continuing to climb. And it's obviously pretty high numbers. And this is an old slide looking at forecasts, which turned out to be fairly accurate. And clearly, obesity in itself has significant costs, not just in terms of diabetes risk, but in certain cancers, particularly breast cancer in women and colorectal cancer in men, cardiovascular disease itself, and also things like joint disease and early arthritis as well. So quite a high risk of various comorbidities now that with obesity that's contributing to the NHS cost. Next slide. And this is just looking at a economist assessment of the world in terms of overweight and obesity forecast, just looking at the economic cost now of the increasing obesity of the population to the point where it's nearing 3% of GDP. So next slide. So you could say, well, how active are we? Within that, what I was going back earlier, within that sort of 70% genetic, of the 30% that's environmental, about 25% of it is calorie intake. It's relatively little is exercise, but that would clearly help. But actually just exercising to lose weight is actually not particularly profitable, but there are benefits in terms of your insulin action when you have diabetes in terms of exercise. And basically, as a population, as you can imagine, we are just becoming more and more sedentary for lots of different reasons. So this is further contributing to the problem. So in terms of health inequalities, again, what people are doing and their activity levels will be contributing to their risk of diabetes. So this is one of my, next slide, this is one of my favorite slides. And I often tell patients, this is me this morning when I was getting up, I usually have a white shirt on, and measuring where the weight is and what it actually is, what's inside our tummies, because this is this classic apple shaped. And just quite interesting on fat as well is that we have like an apple shaped fat, which is this sort of central obesity around the middle of the gut. And we also have gynecoid fat or pelvic fat, which is sort of like a pear shape, apple and pear shape. So some people have a sort of a big bum, big thighs. That's a gynecoid pelvic weight gain. This is a more typical android or apple-shaped weight gain, which is the type that's associated with type 2 diabetes. The other type of weight is not hormonally driven and is actually more difficult to lose because it's not really something you can really tackle as easily with diet and exercise, and it's very genetically driven. But if you say to someone what's actually in your stomach, is that white stuff on the right-hand bottom slide is the intra-abdominal fat. So this is not liposuctionable. The line on the outside, the little white line, is the fat under the skin. That grows back within 6 to 9 months of taking it out and doesn't really address where the fat is in that center of the gut. So that fat is very genetically driven by this insulin action. The more and more insulin you make, the more it acts as a fertilizer for those fat cells to grow. So what people now, the concept is what we call metabolic syndrome, which means, sorry, next slide, you're identifying people with this sort of diabetes risk. They're gathering the weight around the middle. And in terms of actual numbers, if you want to practice later at home, if you go around the worst bit of you around your belly button, once your waist is going above 37 and certainly 40 inches as a man, at 31.5 and 34 in a woman, you've got sufficient fat to be defined as having the metabolic syndrome or insulin resistance. And just to say, every man I ever checked always thinks they're about 4 inches less than they are because they all wear their trousers around their hips. So actually just your trouser size is not a good guide to your waist. And in most shops actually sell those trousers at a lower number to make you go back to buy them again. So you've got to be careful where you're actually measuring this true thing around the middle. And actually, rather than any scans or any blood tests, the simple waist circumference is probably the best way you have of knowing your future diabetes risk. And then you have this classic triad of not only the sugar, but the blood pressure and the cholesterol alongside that central weight gain. Next slide, please. So there are various criteria in terms of the waist, how much your BMI is, and the BMI typically chosen is 30, but it's very much a function of where that weight is rather than, so it's very much that central weight that's the issue, not always your total body mass index. Then there are various other criteria in terms of glucose, cholesterol, and blood pressure. And there are other associated conditions such as gout, polycystic ovary syndrome that are often included in this whole sort of box, if you like, a Venn diagram of lots of different circles that encompass the metabolic syndrome. Next slide, please. So when we're looking at obesity itself, we're looking at the various factors, strong genetics, with their this availability of food in the environment, and then you've got some cultural factors, psychological factors. So this is that in that behavior end of the spectrum, is where you might see more health inequalities in terms of what people can do. Certainly stress can cause quite significant increase. I also say to patients that you can look at the genetics of obesity, that has been done in rats, that if you stress a rat, and that's usually done by rattling a cage, some rats, the first thing they'll do as stress is they'll go to eat something, whereas another rat won't. So you can actually find that most of our behavior is actually driven by the genetics that got us overweight in the first place, not as a weakness on the person's part in terms of how they behave when they're stressed. But clearly, it doesn't take much over years to just slowly increase your energy intake and reduce your expenditure to just slowly climb that weight up. Next slide, please. So when people say, okay, well, how am I going to lose weight? I've been caught in my pre-diabetes or early diabetes zone. I think people just underestimate how difficult it is. And what I normally tell people is that if you go for a sustained lifestyle program, that's the top blue line, it's actually really quite difficult to lose 5% of your weight and stay there. And if you look at the data after a year or two, most people start climbing again. So only 20% even in a manage to maintain that 5% weight reduction. We've clearly got surgery, which can lose the bottom line, the red line there, that can help you lose up to 30% of your weight. And now increasingly, we've got some new injection therapies, which can offer at least a 15% or even 20% weight reduction now. So the medical therapies are starting to approach the sort of weight reductions that we're seeing, that are seen in surgery. So next slide, please. I thought I'd also just mention, because I think it's really important, obstructive sleep apnea, because this is some people know this is a problem with that central weight, is that men notice their collar sizes increase. So often a collar size, they might be 15.5, 16 at 21, and then they're 18, 18.5 in their 40s. And what that means is you've collected fat, not only in your gut, but also in your neck. And so what happens at night is your neck collapses, it opens. And so every time you try and open your airway, the snore is when your oxygen dips. So it's quite an adverse sign for lots of different reasons, poor sleep quality, and that can worsen the insulin resistance and make the problem worse. So obstructive sleep apnea is quite an adverse outcome in terms of health. So I'll go down 3 slides, please, just to move things on a bit. So I just thought I'd just mention, because there's this issue now, can you lose enough weight to send your diabetes in remission? And you can do so, but you are looking at losing at least 10 to 15 kilograms in year 1. And there is a trial that's attempted this. It is available on the NHS. It is a tough challenge. It's 600 calories a day for 3 months with protein shakes, and then 9 months at 1200 calories a day. So if you do that, even then, you're only losing 10 to 15 kilograms, and you do have a chance of about 2/3 of sending your diabetes into remission, which can stay there by 2 years if you maintain that weight. If you slip back even 5 kilograms, the diabetes returns. But in principle, weight reduction can actually reverse diabetes. And in the next slide, and if you can achieve that 15 kilogram weight loss in that first year, you're actually normalizing your life expectancy compared to the diabetic person who might have lost up to 5 to 10 years. So it's quite a key moment to capture people at that early to see if they can maintain that sort of initiate that weight loss and maintain it thereafter. So next slide. So what happens in type 2 diabetes is, sadly, things just get worse. Your reservoir continues to empty as you get older. So by the time you're diagnosed, you might be down to about 20% of your pancreatic function. By the time you get to 5%, you need insulin because you've gone just too far below the line that the tablets will work. So what you have is a slow incremental process of a natural history where your reservoir empties and empties. So over time, you're going to need more and more interventions to keep your sugar levels under control. And so in the next slide, this is just a brief summary of the various treatments we have. We can increase insulin sensitivity. We can help you excrete sugar more easily. We can replace hormones. We can stimulate your pancreas to make more insulin. So there are various ways that we have now, which are all complementary to each other, to try and help or aid lifestyle intervention into achieving what we call target blood sugar control. Next slide. And just to say on this, because it's topical at the moment in terms of these what's called incretin-based therapies. These are the weekly injections you may have heard about that everyone's on now to lose weight. And it's interesting that within the diabetic community, there are quite a few inequalities, both in social class, how doctors treat people, respond to the physician bias, health literacy. It's an injection, which can be an issue. So there's quite a lot now looking at how some people with certain who are disadvantaged in certain areas might be not achieving the weight loss they need because they're not having access to the same treatment opportunities. So this is an example of a therapy where people can access, and obviously if you can pay privately, it's £120 a month now. People are accessing, but on the NHS it's still not yet available, partly because of its expense to the NHS, and it's not yet deemed by NICE to be sufficiently cheap to warrant being very high up the algorithm. But it's clearly a massive, if you can achieve 10 to 15% weight reduction, that has a massive advantage. So next slide, please. So looking at the complications we talked about earlier, the better your blood sugar control. Again, like with type 1 diabetes, the UK PDS was the equivalent trial in type 2 diabetes, looking at long-term outcomes and basically showing that however much you got your sugar down, you started to reduce your risk of all these various complications. So a great incentive, particularly in the younger person, to get your HbA1c to target as early as possible. So I'll go to 3 slides down, if that's possible. So I did just mention bariatric surgery, only because I think certainly culturally we use this relatively little in the UK, but actually if you see someone with new diagnosed diabetes and offer them metabolic surgery, you have very respectable cure rates for type 2 diabetes, particularly. But of course, it is culturally difficult for people to get the concept of metabolic surgery. They still sort of believe they can probably achieve it themselves without quite knowing what barriers there will be. But it is an option that we relatively underuse. So I'll go down 2 slides, please. I just thought I'd just mention diabetic foot ulcers, because in terms of all the complications, this is the one that I've seen, and I've got a case discussing this later, where I think the health inequalities is probably most, where there's more data than any other, that if you are in a disadvantaged group, particularly some ethnic minorities and lower social economic groups, that you are at greater risk of having an amputation once you get a diabetic foot ulcer. Its ability to go to clinics, comply with treatment programs, it's offloading your ulcer with a special boot, various aspects actually that seem to contribute. So this is a key indicator, actually, or key sort of outcome that is very closely related to health inequalities. So the first case I was going to describe is a claimant who had really poor blood sugar control for many years, and he'd had a history of infection. He didn't have any obvious blood vessel problems in his foot or nerve damage. He then developed a second toe infection. He settled with antibiotics, but it was even then noted that he had poor glycemic control, as we would say, poor blood sugar control. Now, this is a young person who would be considered at very high risk. If you're looking actually at a person diagnosed with type 2 diabetes age 40 years or less, you are looking at a life expectancy reduction of between 10 to 15 years because it's demonstrated such an adverse cardiovascular disease outcome. But this is a person who's getting regular foot ulcers. He had tended with a left heel ulcer, was told to go to A&E. He was started on oral antibiotics. He wasn't admitted. He went subsequently a few weeks later, the infection had progressed, and he required a left below knee amputation. This is a very classic history of someone who's not really engaging, not really complying with therapy, not taking medication, poor blood sugar control, possibly disadvantaged in terms of social setting. There may be higher risk of smoking. And then the case really becomes, at what point was the amputation preventable? So the next slide, please. So in terms of there is nice guidance on managing diabetic foot disease, and I won't go through all of this, but there's clearly when you prescribe antibiotics, and the issue is here earlier referral to the multidisciplinary team. which didn't occur in this case. So the next slide in terms of the issues is that the foot ulcer deteriorated despite the oral antibiotics unsupervised. There was no attempt to address glycemic control, or where there was a vascular problem, wasn't referred. Because the advantage of the MDT assessment is you can reevaluate whether you're treating the right bug. You can have specialist podiatry input. You need to offload the foot with a plaster cast, dressings, and you then have the opportunity to improve blood sugar control, offer scans, etc. So, however, the problem with a case like this is that there is a certain inevitability. Next slide. But the amputation may have happened. In total, the risk is about 20% of any diabetic foot ulcer may get an amputation. So the difficulty in a case such as this is knowing at what point you could have changed the outcome, and even if care had been optimal, whether that would actually have reduced the risk of the amputation. So that does make diabetic foot disease and subsequent amputations a very difficult sort of medical legal case, certainly from my perspective, often with a vascular and orthopedic surgeon, to discuss. There may be obvious breaches and lack of referrals, but whether actually those have resulted in the causation of the amputation. Next slide, please. Just to say that there are some simple, these are all going to be referenced, but there are some tools around that can calculate risk. And I find this quite useful because you can put in some clinical data on a patient and just to say what was their risk of having heart failure, amputation, or blindness within the next 10 years. And so if the solicitor's looking for sort of a baseline number, you can say, well, actually, his risk of amputation within the next 10 years was only 5%. So therefore, if the amputation has happened, you can start to provide some ammunition to help support the claimant, or vice versa. Next slide, please. The other thing I think is underestimated is what bad news actually having an amputation is in terms of the 5-year survival. So even if you cross the hurdle of breach and causation, the next problem in that 58-year-old is how long he would have lived for. And the data actually is that your 50% 5-year survival, you've got a 50% survival at 5 years if you've had a diabetic foot ulcer that results in amputation. As you can see, I put some cancers up here to give you an idea. So compared to some of the other conditions we associate with being more serious, actually a diabetic foot ulcer and amputation is bad news, as it reflects your whole cardiovascular system. So that can often limit the damages because that you've got a relatively low life expectancy. So the next case is a rare form of diabetic neuropathy called Charcot-arthropathy, and I mention it because although it's rare, it's not uncommon. And it's a common problem in the sense that a patient will often present to A&E with a swollen, painful left foot. It might just be because they've had a little trauma or something, and they'll be dismissed with an ankle sprain. There may be poor blood sugar control, there may be other complications of diabetes, but it is a condition where if it's not considered or referred urgently, you can be left with a significantly deformed foot and increased risk of amputation. So next slide. So a shark, this is when you've got an underlying destabilized foot due to the nerve damage, and basically your bones in your foot have suffered a mini earthquake. So you get a chronic misshapen foot with swelling, and therefore you're more prone to ulceration and foot destruction, which means you can't wear normal shoes, and it can be very disabling. So it's one of those situations where catching it very early can make a massive difference. Next slide, in terms of limiting the deformity. And so if you've delayed the diagnosis by 2 months, the foot's not immobilized, the person continues walking. Again, the issue then becomes, would an earlier intervention have changed that longer term outcome? And again, you have other significant comorbidities often by the time they get the arthropathy, which will already have reduced life expectancy. So again, a difficult, in terms of the breach, is often easy to show, but the causation and indeed the damage side of things can be difficult to evaluate because of the underlying condition and its association with other severe complications of diabetes. Next slide, please. So the other thing we mentioned earlier, particularly in the type 1, is this risk of hypoglycemia. And this is a claimant, so his case was aged 18 years, type 1 diabetes. And basically the case was that he had a severe brain injury as a result of hypoglycemia whilst he was in supervised accommodation. He'd had diabetes for a relatively short time, known to have poor control. he was non-compliant, he had good awareness of hypoglycemia. So the issue became, and patients like this are self-managed. You cannot be checking their sugars all the time. To some extent, they have to manage themselves. So it's an example of how difficult it is, even in a supervised residential accommodation, how difficult it is to manage somebody in this situation with complex type 1 diabetes. So, next slide. So in terms of, you can prompt them, you can measure them, you can tell one about risk, but if the person misses a meals, if he drinks alcohol, it can be difficult to actually prevent every, and in this particular case, the actual circumstances of how it became hypo were unclear. You might have injected insulin, you might not have eaten. And I remember in this case, there was the claimant, there was 3 defendants, one representing the probation service, one representing the residential home, one representing the GP. This was the first joint statement I did with 4 experts trying to agree about 50 questions in terms of a case, showing how difficult it was to try and prove a breach and then certainly causation. Next slide, please. This is another case of pregnancy, which I know you've had a talk on earlier, and this was actually, I know that there has been recent emphasis on ethnic minorities having access to good obstetric care and whether they're a disadvantage. And indeed, this was an Afro-Caribbean lady who was at high risk of gestational diabetes, which is diabetes that occurs for the first time in pregnancy. She was older, she was overweight, and she had had it in a previous pregnancy. She was referred for what was called shared care. There was no booking recognition of the diabetes risk. She didn't have any monitoring, and she presented with undiagnosed gestational diabetes due to an abscess at 32 weeks. And it was obviously a very tragic outcome in terms of the baby. And she had, on this occasion, type 2 diabetes, which continued after the pregnancy. Next slide. So the issue became that actually by the time she presented at 32 weeks, all medical care had been reasonable. But the previous and what was obviously long-standing high blood sugars long before 32 weeks, due to the unrecognised and unchecked newly diagnosed gestational diabetes, was causative to the birth injury. And we could certainly claim on balance that if she'd been diagnosed earlier, treated with insulin, normalised her blood sugars, then her baby wouldn't have had this neurological damage. In this case, was settled with substantial damages to the claimant. Next slide, please. I think one of the other main areas in terms of diabetes I'm often asked about is that diabetes isn't often the issue in terms of the case, but it becomes an issue in terms of quantum. So this was a person in the army who was injured. The claim then was about the army and his loss of career, etc. A year after the incident, he got type 2 diabetes, for which he was at high risk. He was an Afro-Caribbean. He had a strong family history. And then the issue was whether his lack of mobility and increased his weight, because he gained 10 kilograms in that year, and also psychological impact. And what we could talk about was how the incident probably brought forward the diagnosis by up to 10 years by the weight gain, the immobility, and the psychological impact. Next slide. And coming back to another one of these risk calculators, this is again, I could put his data in at 30 to tell you what his long-term risk of diabetes would have been. And therefore, if he did develop diabetes within a year, you can give some data to show that actually that's a much advanced outcome than what would have been expected on the balance of this sort of community data. Next slide, please. So what you could say is that instead of getting diabetes at 31, you might have expected to get it at 40. You can then anticipate where he would be in terms of his medication over the years. And I think it's important to know that life expectancy in type 2 diabetes, particularly diagnosed so young, can be reduced up to 10 years. And the other factor is that what people don't realise is that the comorbidities that occur in diabetes in terms of the complications start from up to 10 years prior to your anticipated date of death. And so rather depressingly, the expectation is that we usually require 18 months of what we call high dependency care before we die. That's increased to 3 years if you have diabetes, so that would include increase of dementia, stroke disease and things like that. That we might need 50% care needs for 3 years before that. We might need low dependency care needs from 4 years before that. So 10 years before your anticipated or estimated date of death, you are going to need care that you, so again, in terms of assessing quantum, then the issue would be how much care would you have needed from diabetes alone, but for the incident that's formed the case. This has also got issues in terms of work capacity, because the data on type 2 diabetes, and certainly type 1, is that from 60 years you've got a 50% chance of not working full time, and certainly in a heavy manual job. And so some people in a manual job in their early 50s might not be able to retrain. So the question of when they would stop working can form part of the case. Next slide, please. Actually, I'll move on 2 slides. Sorry, just to say, next slide. So just to say, there is the obvious statement that only the old die. This is just a nice slide, I thought, looking at the increased prevalence of the ages, and how the problem now is that with all the advances in diabetes care, that actually life expectancy is being nudged higher and higher upwards. So by the time you're getting to type 2 diabetes and you're alive at 70 to 75, actually your life expectancy is only 2 to 3 years reduced. But what you then have is this long-term comorbidities to make you dependent in those last few years. So it is a sort of that complication is the key thing to prevent early. So the better you control earlier on, the less chance you have of those complications. Next slide, please. So just some overall conclusions of what I've been trying to get across: the importance of type 2 diabetes, the issue now with prevention. How can you put a program in place at the community level in terms of this obesogenic environment? Can you just stop all the cars, make everyone walk? Can you change the sugar in foods? Can you change the advertising? How can you, as a population level, start to reduce obesity, which will translate into type 2 diabetes? The complications of diabetes and their prevention are key, because those are what translates into your reduced quality of life before a slightly reduced life expectancy. In terms of medical legal issues in diabetes, life expectancy, morbidity prior to age of death, employability, specifically diabetic foot disease, hospital complications and pregnancy form the bulk of the work in diabetes. And in terms of health inequalities, what is clear from the work that's been done, particularly in these NHS groups, is that education with the high-risk ethnic groups, making the education resources accessible to people who may not be able to read or speak certain dialects or languages, getting whole communities involved, because often whole communities such as Bangladeshis, for example, might be at very high risk of diabetes themselves. Raising awareness of diet and exercise, awareness of service and how you access them. I've not mentioned frail people who live at home who don't have access or can get to their GP for their health screening. People with learning disabilities and mental health conditions, again, are often neglected within the diabetes care package. Residential care or housebound, another issue. And I think particularly with the type 1 patients, you are requiring a high level of, I know that with youngsters now, they seem to do it quite well, but there's a high level of IT skills necessary to help manage what's a very complex condition. Thank you very much.
Thank you so much, Dr. Vanderpump, for that really interesting and informative talk. We do have a couple of questions that were actually asked in advance, but if you do have any more questions, please do pop them in the Q&A chat. So we had a question from Daria, who is a solicitor that actually joined our firm this week. She said, is there a rule or expectation that the standard of care would be higher for a person with diabetes than those without? She says she recently had a case where a person with diabetes was treated for an infection following insect bites, and the expert said that the standard of care was not breached, but the defendant's trust admitted liability on the basis that the claimant was diabetic and required more invasive treatment to prevent the spreading of infection. Is that a common approach?
Yeah, so I think the issue with infections, and I had a young person this week who had just a whitlow, a finger infection, which was quite nasty, that sort of needed pus expressed and antibiotics, is that it does depend on the characteristics of the person and then being assessed as to their likelihood of infection progressing. So that's mostly correlated with their blood sugar control. So the problem with high blood sugars is that your white cells, which is your main army to fight infection, just don't move as quickly the higher the sugar. So there is reasonable sort of community-based evidence that the worse your overall blood sugar control, the more prone you are to infections, particularly staphylococcal skin infections. So if you're seeing a person in A&E who has diabetes, it is part of your care to assess their diabetes control to see how much they are at risk. And that you have to be aware that potentially in the diabetic person or the person with diabetes is that infection could be more severe than appreciated. So I think that in that particular case, there would be a higher observation, more intense antibiotic. You might lower your threshold for IV antibiotics, etc. So there would be a whole package that you put in place to safety net someone with diabetes that you might not necessarily do for someone without diabetes.
Thank you. One of the other questions that was submitted in the chat was also submitted beforehand, I think, from Anne from the NHS. She said, thank you for the great information. She said, especially about the mention about stress being a contributing factor. She asked, when will the fructosamine testing take place as standard on the NHS together with the HbA1c, because anemia has been known to skew HbA1c results? Yeah.
So just to say that many years ago, before the HbA1c became, and the reason why the HbA1c was used, by the way, is that that was a 3-month average of your blood sugar control and was the outcome measure used in all the trials for complications of diabetes. So that's why we have it as a standard. The fructosamine was the method we had just before the HbA1c was introduced. And the fructosamine is a measure of your control over 6 weeks. So there was a slight disparity between 6 and 12 between the two averages. There is a calculation where if I measure the fructosamine, I've got a table where I know what that means in terms of your HbA1c. So you can still use them. There are reasons why the HbA1c can let you down. And as the questioner indicates, if you're anemic or you've got an increased red cell turnover, your HbA1c can be unreliable. And so what you can do sometimes is use the fructosamine to see whether you're in the right ballpark. I would say the commonest reason we probably use the fructosamine, or I use it now, would be if patients have got sickle cell anemia or sickle cell traits, you can't rely on their HB being a normal structure. And so as soon as it isn't, it doesn't register in the laboratory machine. So it's a laboratory issue. That means you can't use it, so that's why you use fructosamine. But it's very much, I suspect, a specialist test. It's not used routinely because we would only use it. So in renal impairment, renal failure, where you can have increased red cell turnover, might be an example of one that we'd use. But it wouldn't be. It still would be relatively rare to get requested and organised with most laboratories at the moment. And it won't replace the HbA1c, partly because all the data to date is on the HbA1c, and that's what the WHO have used in terms of diagnosis as well. I've got a question here from the COVID pandemic issue, which, and this is where all the clinics were put on hold, and I think even now some of them still only telephone and just getting back into action. I mean, I think the key thing here is that for most persons with diabetes, they had a two-year at least hold on anyone reinforcing their treatment, because I think there's a lot to take in. Every time you see someone, you've got to keep repeating the message to make sure they're on board with all with their management. So I suspect that with much like with every other condition, this 2 year where nobody really had things measured or monitored will be brewing further complications somewhere down the line. So I think that is a good point. The other point you remember with the COVID pandemic, of course, was that it was clear at the very early stages of the pandemic, both in China and in Italy, that the diabetic patients were much more likely to end up on ITU in terms of particularly overweight and have bad outcomes. And also there was this curious phenomena that the coronavirus actually damaged the pancreas specifically. So there was a cohort of patients, particularly in the first wave, who got diabetes after they recovered or made their diabetes worse, i.e. they lost beta cell function, particularly during that first wave. So there was quite a lot of good data. And in fact, the excess mortality in the diabetic population was quite considerable because they weren't being managed, they weren't being recognised at home, and there was not an awareness then Plus, everyone was given, if you remember, high-dose steroids in that first wave, which would have made sugars worse as well. So quite a lot, the diabetics were majorly disadvantaged in that first wave of COVID. And just going back to the stress issue, I think we have to remember the stress is actually quite a difficult concept in terms of biology. So it depends what we mean by stress. I always think there's an acute stress, whereas someone like, if a tiger ran into my room now, I'd run. That would be an acute stressful experience. Or I could be bullied by the nurse for 6 months and have chronic stress because I've been bullied, and every time I come to work I get anxious. So when you're thinking about a stress response, you've got your acute hormones that make you run, if you like, fight or flight, and you've got your chronic hormones, cortisol, which are more involved in the chronic stress response. And sometimes that's what, I mean, people get mood disorders. That's why they lose their sleep, because they lose their diurnal rhythm, because they're producing cortisol all night. Some people are much more prone to weight gain because of cortisol action. And there's good evidence that it can cause deterioration in control in both type 1 and type 2 diabetes. So quite a complex area, but it is difficult to, it's a sort of a holistic health model rather than something that's so easy to measure. And I think I've had a few cases where someone's had a stressful experience and then got type 1 diabetes, or something happened. It's still quite difficult at the medical legal level to prove that the stress was implicated and at sort of in terms of probability. So it's quite a nice, helpful model for patients. And patients are often told things like, oh yes, you know, you had a bereavement, you got type 1 diabetes 6 months later, that's why. But actually that's very difficult to prove at the legal level.
Thank you for that. I know that stress definitely affects my blood sugars, and it is really difficult to control in that sort of sense. So I don't think we have any more questions. If there are no further questions, just to say thank you again to Dr. Vanderpump, and thank you for everyone for joining today. It's been a real privilege to have you join us. I think on the next slide there should be some contact details if you'd like to get in touch with us in the future. And if you take a look at our website, you'll find lots of other webinars and useful information. If you also follow us on social media, LinkedIn, Twitter, anything like that, you can stay updated on any legal updates and any future webinars. As mentioned earlier, there will be a feedback link circulated, and it'd be much appreciated if you could fill that in for us. And I hope you enjoy the rest of your day, and thank you very much again for joining us.